that's the kind of thing that you have to consider. And as an example, I'll tell you, during my own training, it was interesting. My subconscious was so active. I didn't ever really think that emergency medicine was a good fit. I picked it because I didn't know what else to choose. And medicine in the United States is so specialized now, you really have to pigeonhole yourself into things where you really exclude most of what you're trained to do once you enter the second phase of training, which is residency. So I picked emergency medicine because I wasn't willing to give up any of the other stuff that I learned. I figured someday I'll figure it out, and then I'll be able to, transition to whatever that is. But until then, keep it broad. And it turned out to be a really good fit in the end, as I discovered only after doing it for a few years in residency. But what happened is I started dreaming about all of these different scenarios. It was really, they weren't nightmares, but things that I had not experienced clinically came up in my mind over and over and over again. And at some point I realized I think I was actually working out the emotional and mental response that I would have in an unknown situation, in weird chaos that has to do with medical trauma or medical illness. And the interesting thing was I experienced most of those things in real life, either during training or afterwards in regular practice. And they were really bizarre things. Like, one thing that I remember from a long time ago when I was a kid, taking first aid is, what do you do if some kid comes up to you and stabs you through the eyeball with a pencil? And I remember waking up one day before going into a shift and thinking, wow, I had this hour-long dream about some kid with a pencil sticking out of his eyeball. That's pretty gross, but I know in my state of mind, I can imagine it and I can handle it emotionally at some level without freaking out. And sure enough, over the years, I saw lots of kids and other people who were stuck through the eyeball with something or other. And I would always go back and think, I knew how to handle it in my subconscious. I knew how to go back in my subconscious. I knew how to handle it. It's a really interesting realization.
It's working.
It's working. From your phone or just?
Yeah. I was just checking to see if it was working.
Wow. That's amazing. But not on the technological amazing system that you've got set up there next to the phone?
No, I'm broadcasting. I'm watching it.
Nice.
To see if it was going out. You're good.
So for anybody that's joined us on YouTube, we're in the preamble whereby I'm talking about my subconscious focusing on weird shit that happens in emergency medicine. Can you say that kind of stuff on YouTube?
You do whatever you want.
Okay. The incident that we're going to talk about tonight was written up by a Dr. Menez, who was one of the primary emergency physicians on duty at a level 1, but a smaller level 1 in Las Vegas. And he had spent years considering how he would respond to a mass casualty shooting incident. He had a little bit of military background, and he was always kind of the weird guy at the party when he started talking about this kind of stuff, because people would say, you're perseverating on something really bad, and to spend all of your time thinking about it isn't necessarily a healthy thing to do. But this guy is a very level-headed physician. He's experienced, he was a good fit for emergency medicine, and he thought about this stuff in a way that allowed their hospital to deal with logistical problems, nightmares, and some hospital administrators' worst dreams, that allowed them to respond in a flexible way to something that was utterly chaotic and overwhelm their system in a way that they actually were able to, by thinking out of the box, because he'd already spent so much time considering these scenarios, to do things in a manner that worked. And he wrote this up in one of the most compelling medical pieces I've ever read in 25 years of doing emergency medicine, because he had this thought process, and it made sense to me, having been in those kind of chaotic situations, And it was really about a subject that I had a lot of reluctance to think about because I just thought, if it happens, we'll deal with it. But reading his words and his description of what happened that night made me think this is a good subject to cover because there are some lessons that we can learn. We may not get it perfect, but there are some things that most hospitals do. And the focus in this really is on the hospital side, but there are some lessons for EMS. But in almost every hospital system I've ever worked in, the protocol that drives our response to a level 1 situation is what they call it in Miles. Basically a mass casualty that overwhelms the system is always protocol driven from an administrator top-down level that doesn't work very well because it takes too many people and it's too resource intense. And the patients who need treatment don't get an efficient processing. They're chokeholds rather than having a system that eliminates all these barriers and just makes things work. So that's the basis for the stuff that I'm going to show you. So this happened 2 years ago, roughly. It's almost October 1st, so it's almost 2 years to the date. 10 o'clock at night. And I think I'm going to see if I can. This is radio traffic.
169K, we got shots fired at 4:15 a.m. Route 91, satellite automatic firearm.
Okay, so right in 169 Sammy, we have shots.
What's going on, Sammy? Coming from upstairs. Get the Mandalay Bay. Upstairs, Mandalay Bay, halfway up. I see the shot coming from Mandalay Bay. Halfway up. Control 361 IC. We have multiple orbits. Hey, break. Give me a surge. We have an active shooter. We have an active shooter inside the fireground.
Shots fired from Mandalay Bay. There's many people down. Stage left. Just be advised.
790 right. I'm going to forward strike the Mandalay Bay and the Boulevard. I need 5 officers on me.
So that's a compilation of some radio traffic that includes EMS and law enforcement at the time this went down.
169 Sammy.
Let's see. So this happened in Las Vegas, which has a metropolitan area of several million, at the scene of this outdoor country music festival with tens of thousands of people in attendance. One shooter who was located with planning on the 32nd floor of the Mandalay Bay Resort with a field of view that included the entire fairground. 911 got 1,500 calls in under 2 hours. You can imagine that was chaos in and of itself. And it resulted in about 1,000 people who were shot by one guy. So he must have shot 2,000 or 3,000 rounds with a bump stock. And he had bags of ammunition, multiple guns. He had backup plans. He had, you've read the news. This guy had planned this out for a long time. Here's another clip.
There's a large crowd running from the music festival down here. Do you have reports of anything? It sounds like gunfire.
We got multiple metro units moving that way. We don't know what we got just yet, so please be very careful making your way in on this.
Reports of automatic gunfire at the Route 91 concert in the village across from the Luxor. We can't approach it yet. Also reports of somebody shooting from Mandalay Bay. Command post is going to be at 4,800 roughly the Boulevard South. Leo's going there now. We haven't been able to approach because we're not quite sure what's going on just yet. We have equipment staged at Chop in the Boulevard and also down in Russell in the Boulevard.
I'm getting reports of 10 victims at Russell in the Boulevard.
I got 4 patients, I need transport 4, and I need at least 2 additional fire apparatus to assist with triage down here.
We have 2 gunshot victims, activation 13. The operations airfield persons have delivered them to our station. We're treating them now. Written incident for SWAT 13.
We are out of ambulances and we still have a couple more criticals.
Engine 32 to engine 33. Engine 32 2. We had at least 6 additional patients inside Hooters. 6 additional patients. Copy, 6 additional for a total of 12 now at Hooters.
Okay, Leo, we're getting a report of a person in fatigues, and going into an RV in the area of Hooters. You can relay that to Metro. They got 1 officer there. They're requesting more over there. They're not sure what this person's status is. All personnel on scene be advised that we have pickup trucks full of people coming to the Hooters location.
Information I have reported 15 patients as NGM at the triage center.
Okay, all personnel with safety messages. We have a report of an active shooter at New York. Report of an active shooter at New York, and possibly more patients at MGM. Not quite sure what's going on.
Command, this is Rescue 6. We were responding to Los Vegas Boulevard at Trump, and we came across 2 gunshot wound victims at Dean Martin, Tropicana. We will be transporting them to the hospital. We have a hospital destination.
Rescue 6 be advised UMC is completely out of bed.
That's a bad thing to hear as an ambulance transporting critical patients. So that gives you character, just the character of this is just the radio traffic of how chaotic the situation was. There are at least 5 different resorts that are receiving patients. These aren't medical places. These are just like resorts where people are walking in through the door, dropping down. We've got hospitals already calling in saying they're full, which usually leads to the next thing where somebody who doesn't have much authorization says, we're closed, divert, which is usually not legal, but you hear that a lot. Ambulances are in short supply, and it sounds like the number of wounded or the number of patients is spread out over a wide area, which doesn't usually lend itself very well to our typical mass casualty setup, which is staging everything, having incident command, and having everything in one centralized location. So I'm going to detour a little bit and just go over the main EMS guidelines. Actually do have very good information on, at least broadly, how in our systems we're trained to deal with these things. So this is straight out of the EMS guidelines book, which you all have on your phones as well. There's 2 pages that are relevant, but I'm just going to show you this page first. There's not a lot here that is new, but the basic parameters from that first page are, first, in most of these chaotic situations, there is a potential for hazard to responders. And we know that in some of the more urban areas or in international incidents, especially in Europe, where there have been terrorist bombs in populated centers like Paris and London, that there is usually a plan for the most diabolical of the people that are doing these things of actually taking the second or the third response tiers to the initial scene and having a second accident or explosion or gunfire. So it's very, very important, as you're going in, that you're cautious and you understand that there are risks. In the case of an active shooter, the police are going to be responding with you. It's just important to be sure that you've got protection, and when you're going into a scene, that you balance your own safety versus the safety and the needs of the patients that are there. And sometimes there's a dilemma. I've been in situations in my own career in New Orleans. I lived down there and worked when we had a number of housing projects that were really filled with very, very poor people, who lots of alcohol and drugs. Everybody had automatic AK-47s. That was a thing you could buy on the street back then. Everybody liked firing them in the air. And there would always be responses, and we would go into these places and be surrounded immediately, an ambulance, by 1,000 people, literally, at night, no lights, and everybody was really, really on edge. Now, going into a situation like that with the uniform, the health status, we generally were considered to be very friendly. But I remember the paramedics that I worked with, we actually wore bulletproof vests, and in some cases, especially in holidays, we wear Kevlar helmets because of the bullets that were coming from the air. But they were very, very diligent about making sure that they had a way out, and that if they smelled or felt like the situation got bad, that we would have an exit strategy. But that didn't prevent us from going right in the middle of these places, picking up all the bodies and sloughing them back to the ambulance and getting out. And in almost all of the cases that I heard of, and all the cases I ever was involved with, I remember the lesson I learned was the patients are really, really important. And if the police tell you you can't enter a place, make sure that that's really true, because if the patient exsanguinates, you don't have any other options. So time has to be balanced against the safety hazard. In this particular case, we know after the fact that the gunman at Mandalay Bay was targeting EMS and law enforcement. Anybody that looked official was somebody that was of a priority. The second thing that is in our guidelines is let dispatch know that there's an incident. Usually this comes from dispatch, but when you are radioing in, the most important thing is to provide as objective a picture of what's going on as you can, because most of the data that's coming in is fragmented or based on some conjecture. So the type of MCI, estimated number and type of patients, and then the type of assistance that you think you're going to need. If you're out there and you need more police, if you need fire, if you need hazmat, those are things to transmit early on. And this is common sense, but this is in the guidelines and it's good to repeat it. Almost forget. Yes, it's important as far ahead as possible to just let dispatch take care of notifying all the area hospitals. So we generally get a call in the ER. This is what we think is going on. Just be prepared for the possibility that you might be getting a lot of patients. And that gives us time to set up, at least calling more people if we need to, change the bed arrangement, get patients that are non-critical out of the ER so that we have space to receive them. And then in the traditional mode, if you have, let's say, one of the scenarios that I hate to think about is a school shooting. Or we can make it a little bit less nasty. A big festival like the Lobster Festival or Waldemar Days or someplace where you know ahead of time there's going to be a concert, a lot of people. So you have one group, one area where you can set up to receive and transport patients. So our guidelines say you need to have a central command. And the central command is generally considered to be the first vehicle on scene that's got communication ability. So it can be a truck, first responder that's got a radio that can go to dispatch. It can be EMS, it can be fire, it can be a police officer, as long as there's a way to actually communicate with dispatch so that resources can be brought to bear. And if it is an ambulance, one of the things that our guidelines suggest is in order to allow use of the equipment that's on the ambulance, because the ambulance is going to be used for basically communications only, is anything that is of value for working that scene for patient treatment, just dump it outside so somebody else can get to it, and then you can have the ability to just dedicate that vehicle for communications. And then the final thing, which really is something that I've thought about a lot, is designating roles. So here's the problem. You have an extremely chaotic situation. You get the 911 call, shots fired, we don't know what's going on, ambulances roll, somebody gets there as a first responder 5 minutes ahead and says, there's a lot of people down. So you immediately know there's something bad going on. The ideal situation is that when you roll in with an ambulance, there already is an entire coherent stage set up for you. So you know where the patients are, who goes first, somebody's directing traffic, all of those things are laid out. You're talking about usually a scene that's under an hour in total duration because you're trying to scoop as many patients as you can and get them to definitive care. and you've got less than 5 minutes to set up a temporary command post with triage, treatment, and ambulance direction in a way that's coherent, that works. So you need a lot of people to do that well. And in our guidelines, there's a minimum of 5 people that are directing different things and taking different roles. In reality, it takes a lot longer than 5 minutes to set up and stage an area well. And usually you don't have 5 people who you can designate to all these different roles because everybody is trying to work patients too. So it's important to look at these as suggestions, but remain flexible if you come up with a situation that needs a little bit of a change in how this is done. But in the ideal situation, you have these different roles. And the first one is incident commander. And that's not part of this. That usually, in an ideal situation, is thought of somebody that's not medical. It's a person that's designated to coordinate all the different types of responses. So fire, EMS, law enforcement, maybe hazmat. So the incident commander kind of oversees all of that. In reality, if you're the first responder there, you're going to become, at least for a small period of time, the incident commander until somebody can take over that role. After that, for EMS purposes, there's a control officer, and that person is the person who basically first sets up the patient areas. And the patient areas roughly are divided into patients who really need transport now or immediate treatment and transport, and on the other end of the spectrum, patients that don't. And generally there's a third region of people that you're not quite sure they're sick, but they're not like the first ones to go. So those are designated, I think in our system is red, yellow, and green. Let's see where we go. Okay, and that person also initiates the triage, the treatment, and the transport areas or roles. So that person basically just looks over the scene in a nutshell and says, okay, we're gonna set up bad patients here, better patients over here. We're gonna have the ambulances come in over there for loading and transporting, and we're gonna set up treatment areas once the patients are there with the supplies that we have in these areas. But that's a fairly overwhelming job because you're also looking at a lot of people laying down who really need your help right now. So the other roles are designated to help that first EMS control officer. So there's a primary triage officer who is the person who then breaks off and starts to say, these are the sick patients, these are the sick patients, these are the sick, and basically directs the patient traffic. That person's job is important enough because as we're triaging, we're trying to do the greatest good for the greatest number. And in some cases, the greatest good will involve some treatment. That's like opening an airway or giving somebody something to do to put their hand on a gusher or a place that's really bleeding and pushing. But that person's role is not to break off and do definitive care or spend a lot of time in one place because of the needs of the many. So that's basically the idea. It's the same principle that we all know of as triage. Then there's a secondary triage officer, and that person assists the first one and helps move the patients. In our system, we also have the tag system, which helps delineate which patients are the sickest and which aren't. We're going to talk about that more as we go down the line. We keep tags in all the vehicles. They're accessible. One of the criticisms that came out of the Las Vegas incident is there wasn't enough time to put tags on people. There were too many people, too few tags, and by the time you get to the hospital, they're re-triaged anyway. So the general idea, though, is that a second person comes in to assist to help move the patients into the right areas and help the first triage officer. Then there's a treatment officer, and that person actually stays in usually the most critical area and starts to use the supplies and provide more definitive care. So that could be intubation, starting IVs, doing things while the patients are waiting for transport. And then there's the actual logistics of getting patients into the ambulances as the ambulances roll in and out. And the state recommends that you have a dedicated person to help with that, so that the person who's treating and the people that are moving patients into the right areas don't have to break off just to load people in and out of ambulances. So you can see that's the ideal system. You're talking about really 5 EMS personnel dedicated to this, independent of the people that are actually doing the transport or the treatment in the ambulance, and an incident control. It's a lot of people for this kind of system to work. And the loading officer also is responsible for communicating once the ambulances leave to Penn Bay. You're getting 5 patients, ETAs 15 minutes, 5 minutes, whatever, so that the ambulances can concentrate on treating the patients. This is another page from the main EMS guidelines, and it kind of gives you a pictorial vision of the ideal scene. And in the kinds of well-localized casualty incidents or hazmat incidents, this is attainable. But this is an ideal situation. These are the triage tags. Do we still have black triage tags? Do we use those?
No, they're tear-offs.
Oh, they're tear-offs. Okay, so our tear-offs have all the colors on them, and you leave the one on that is appropriate for the patient.
Yeah, it's the black at the top.
So the one color that isn't on here that I read about in the Las Vegas scenario is orange. And orange is a little bit worse than yellow here. The greens aren't transported. So in the hospital, at the receiving end, the triage system is a little different because we don't get any of the greens. So there still is red, actually there's still black, red, orange, which is not quite as bad as red, and yellow, which can wait but still needs treatment. Okay, so back to the Las Vegas scenario. These were the problems that came up when we tried to apply the ideal way that we have and have practiced with what actually happened. So the first problem was that the concert was so large that the wound and the field of shooting was so wide that patients were scattered over a huge area, 4 square miles. And so you can't set up one place and expect somebody 4 miles away to somehow drag their sorry ass all the way to your triage area. So you'd have to set up multiple scenarios. And what actually happened is patients self-triage, or people were picking them up and dumping them off in any place that looked like there were gatherings of people that could help. The second problem was that most of the hospitals didn't have a clue what was going on until dozens of patients were just dumped on their door. And that was because of the third problem, that 80% of the patients that went to the hospital did not arrive by EMS. An amazing statistic, and hard to believe because Las Vegas has a very mature, well-run EMS, lots of resources. And you heard the traffic. They were trying to work it. They actually had a lot of, they had a pretty good idea of what was going on. They knew where to go to pick up the patients because they were being called by all the different resorts that had patients, Hooters, whatever. But the fact was, even with that level of coordination, most of the patients arrived by either private vehicle or by police who just scooped and ran. And it's hard for me to imagine a situation where I'm working in the ER at night and I get a call from EMS that there's something going on, and then 80 people show up on their own and 20 people come from EMS. It's like you have no way to plan for that. So that's chaos in its best form. So in the local area, there probably were about, there were somewhere around half a dozen hospitals that had the capability of treating gunshot wounds that were the receiving hospitals. Of those, this is the hospital that we want to focus on. So it's a place called Sunrise Hospital. They actually have a lot of operating suites. They have neurosurgery, which is important because there were a lot of headshots. And these 4 physicians were on duty that night. One of these guys, the bottom right, is newly hired out of residency, just graduated. The other 3 are seasoned. The guy that has the big eyes is the guy that has thought about this a lot. So it's these guys. That guy's name is Kevin Menez. So they had 4 on duty, and their hospital got about 25% of all the people that were shot that night. Most of their patients arrived by private vehicle, and most of their official transports, the ones that they were notified by radio, came by police rather than UMass, which is fascinating.
I heard that's the same thing that happened down at the Orlando shooting too.
Yes. Yeah. And you know, there have been a lot of really interesting studies about patient outcomes, because we spend a lot of time training and providing really important patient interventions. Like, you know, for gunshot victims, I think having a patent IV is so important. If you get it in before they collapse, you have so much more to offer a patient when they need to be transfused and go to the OR. And that doesn't happen if somebody arrives in a private vehicle or in a police car. But there have been at least 3 or 4 studies that I've read. The best one came out of San Francisco, and it was called the Yellow Cab Study. And they compared the outcomes of people who had significant trauma, including penetrating, but not just penetrating, but they had Apache scores, which is a measure that we use for trauma, that were very severe. And they looked at the patient survival rates in the group that came by ambulance and the group that came in any other form, usually private vehicle. And there was no difference. In fact, there was a little bit of difference in favor of the people that came by non-ambulance, which blew everybody's mind. It's like, well, what are we doing? You know, should we just does that mean we eliminate EMS and just say you're on your own and everybody can call it cab or what? So I've never.
Aren't they doing that?
Can you imagine?
Uber should be busy.
So Uber, there's Uber X,
It
there's
actually
Uber
became
XL,
a building.
there's Uber
Yeah.
That's what
WTF.
Not in my.
Nobody ever really quite knew what to do with that. And my personal feeling is I know anecdotally of hundreds, if not thousands, of cases of people that would have definitely never survived had they not had interventions by EMS in the field or in an ambulance. But it's an interesting concept. So really the point is, if people come by ambulance or if they come not by ambulance, doesn't really matter. You treat them the same once they get there. And in an MCI, you have to anticipate that many, many people, maybe the majority of your patients, will arrive to the hospital without notice. Just boom. So this is one of the things that Dr. Menez really harped about, and this is something that he went over in his mind, is they had tags at the hospital too, but they were overwhelmed with so many patients and so many critical patients at once that he thought if we even take 2 nurses or respiratory techs or anybody, actually you have to have the skills to be able to tell if somebody's going to die or not. So it's going to have to be somebody at a pretty high level. You take them out of circulation and you have them assigned to going around and saying, this person is good, this person isn't, and writing it down, really writing it down, or doing something that takes a little bit of extra time. That's a patient life that is not saved because of the time. So really his focus was on time. So instead of actually tagging them, they set up their ER. So there is a receiving area for the reds, there is a receiving area for the oranges, and then for everybody else. And they just set up physical zones. And what this guy did is, let's see, he basically acted as a triage officer for the first part of it, and he would just say, orange, red, yellow, orange, and then the people that were actually out in the ambulance bay helping him would just move those patients in. So that cut off a level of delay and worked very well for them. So this is the way that they responded when they first heard there was something that was bad happening. The doctors told their secretaries basically to prep the operating rooms. And this is something that I've also thought about. You know, we're in an area now, we used to have both Penn Bay and Miles, our closest hospitals, had the capacity, at least at night, to call in OR teams and have surgeons who are willing to do what we call damage control surgery, which is in penetrating trauma, if you hit a major blood vessel or a vascular organ like the spleen or the liver, and it's bleeding, we can only do so much from the outside. We can give blood, we can put pack and dressings on, we can stuff the wounds with some kind of hemostatic agent, we can give TXA, which is sometimes helpful and help them clot. But if the blood keeps going out internally, the patient dies. We had a case recently that I reviewed where a woman who went to Penn Bay at night after a complication of a colonoscopy where the GI person ruptured her spleen, died because she bled out internally. And it was because of a delay to the operating room. And it was because our systems are no longer so general that most of our surgeons are willing to come in and do damage control surgery. So that's one of the limitations that I can see in our system in this region, is having enough willing surgeons to come into the operating rooms to at least, so damage control surgery usually means you do laparotomy, which is just a midline incision, open the person up, see where the bleeding is, put a whole bunch of sterile gauze on it, and bind the whole person up with an ACE wrap, and then helicopter them to Main Med or Central Maine or someplace where the trauma surgeons spend 14 hours fixing everything else out. But you stop the bleeding at the source. And unfortunately, in a rural area like this, it's very difficult to attract surgeons, and it's very difficult to have surgeons who are working in our area feel comfortable doing things that they haven't done in a long time, sometimes since residency or ever. But my belief, knowing most of the surgeons in the area, is if we had an incident like this and we called them up and said, look, Chuck, we've got 50 patients coming in and 15 of them are not going to survive transport to the definitive trauma center. All we need is somebody who's willing to cut them open, pack them, and wrap them so that they'll make it the next 90 minutes or so that it takes to get them from here to the OR in a definitive care setting. And I think most of the surgeons that I know would be willing to do that. But that's still one of the unknowns and the chaos things. In this particular setting, at Sunrise Hospital, they could do that. They called everybody in. They just basically said, we're opening this. Remember, this started at 10 o'clock at night. So now we're talking 11 o'clock is when stuff's really hitting the fan. And they opened every operating room and they brought everybody in from home, which was probably a communications feat in and of itself. They're calling a lot of people. Second thing that they did is they cleared all the patients out of the ER. Everybody was cleared out, and they basically set up areas for treatment for the most critical patients down to the people that were basically the red zones and the orange zones were set up so that really everybody got bilateral IVs. and this is actually a good lesson that rolls down to EMS. In these situations, many of the people, if you're transporting and you have time, may not need an IV at the time that you're transporting them. But if that's done, that's 5 minutes less or more than 5 minutes less for somebody who's going to be a nurse or an IV tech in a hospital setting, who's going to be overwhelmed by the sheer number of patients. And by the time they have to have an IV, they're really difficult to put in because their veins are all collapsed because they bled out. So in not just this kind of scenario, but a typical scenario is a motor vehicle accident with somebody who looks kind of frail or is elderly, who looks pretty good, but may have a head injury or contusions or maybe a little abdominal pain. If you put an IV in those people for us in the field, we're so happy. Even if we never use it, it's done, and for the people that need it, it's life-saving. So in this case, they told the nurses 2 IVs, everybody that hits the door, just in case. We have a lot of different words for this. They have a code triage, which basically means everybody that isn't doing something right now, get to the ambulance bay, bring a wheelchair, bring a bed, whatever it is, line them up out there because people are going to be coming in. We've got to move them from there back into the place where we're going to tell you to take them. So this is Dr. Menez. I'll call it out. I'll tell you guys where to go, and you guys bring these people in. So this is how their ER got set up, and it's pretty traditional kind of ER setup. There's an ambulance bay. There's a CT scan close to the ER. There's a triage area by the waiting room, and then there's all the beds in the ER. So he said I would pull a patient and yell rapid track, station 4, station 2, station 1, because he knows those are the areas designated for certain types of patients. Staff would then wheel the patients to those areas, drop them off, and come back for more. So the second issue that he identified is actually it kind of goes along with this whole triage thing in tagging. So he felt that the traditional triage thing where you're tagging people, but also doing things like vital signs takes up too much time when you're overwhelmed and you don't have enough people to help you. So his deal was identifying people instead of taking actual measurements by looking at them for one of 3 criteria. Anybody that looks like this gets into the top level group or maybe the second level group. So that's bad skin color. And you all have seen people who are in shock or who bled out a lot. They're pale, they're clammy, they just don't, their color isn't right. You look at their eyes, you look at their lips, their tongue, it's just a little off. It's like a Halloween mask instead of the real thing. People that are confused, who aren't quite making sense. In a situation like this, everybody's going to be panicked, everybody's going to be freaked out, but there are people that you can identify that are clearly a little bit further than that. Those people are critical. And the last thing is feeling for a carotid pulse. If you can feel the carotid pulse and it feels thready and weak and fast, that person goes into the critical area. So these are 3 very, very simple skills. Everybody can do them. They identified the vast majority of people that needed to be identified that were seriously injured, and they did it. You could do this very, very quickly, just usually by looking at somebody and if needed, putting your hand on the carotid pulse. Bad skin color or clammy skin, bad mental status, bad carotid pulse. The second thing that he mentioned is the orange triage area isn't something that all of us have heard of. We've got black, we've got red, we've got yellow, we've got green. In his mind, the concept was the people that need to be treated immediately, you can pretty much figure them out. They're unconscious, they've got a gunshot to the head, they're bleeding out, they don't have a pulse, stuff like that. But then you got a group of people who look semi-okay, but they might be a little groggy, they might have a good carotid pulse, their skin color's still good, but you know, your gut is, the guy's got a gunshot wound right here, and he's starting to look a little groggy. He might survive another hour, but you know, in the next level, over that hour, that's the guy that would have gone to the red area immediately if he looked like those guys. So you're layering people so that you can deal with the people that need you the most, and the people that are waiting are crumping, but they've got the 30 minutes or the 20 minutes that you need to spend on the people that aren't going to have 20 minutes. So as you're moving these people out, and the premise is all based on moving those people out, these people now are the sick ones, and they come into your area, and you can do the same stuff for them. So at least you're keeping everybody alive. I spent a lot of time in residency learning about penetrating trauma and treating people with gunshot wounds. In my day in New Orleans, it was had the highest homicide rate in the nation for a lot of weird reasons. Lots of guns, lots of crazy people, and we saw around 10 to 15 gunshot wounds in our ER every day. Yeah, it was amazing. This is during the era when the whole Kosovo situation was going on, and we were doing NATO airstrikes. And at one point, the U.S. military sent all the medics to ride with us in our ambulances because it's one of the few places on Earth outside of Kosovo where you could see AK-47 gunshot wounds every night. So that was an interesting thing. But fortunately, even with all of the guns in Maine, I think I've taken care of one person with a gunshot wound, and it was an accidental. Yeah, it was accidental. It was a hunting thing. The guy was drunk, and they were illegally poaching deer. Right, this family. This is a long aside. It's a funny story because I knew these guys had been doing, because they actually came by our house. Four guys in orange, all had shotguns, drinking wild turkey. It's a great combination, hunting and drinking. And they had, basically cordoned off an area, and they did a search grid to drive the deer to another place where their buddies could shoot them. They didn't find any deer by our house, so they moved off to another area. And I happened to be on duty like the next night, and this guy comes in, and I guess after 4 or 5 days of drinking, they got a little frustrated. And even though the guy next to this guy was wearing orange, he thought, something moving over there, and just peppered the guy with deer shot. The guy was fine, but he didn't hunt after that. The police were pretty clear that it violated a lot of hunting premises that were really important. So one of the things that I want to just talk about with a couple of slides is what happens inside a person's body when they're shot. You see a lot of stuff on TV where you see somebody shot and they fall down or something happens. Inside the body, a lot of different things happen. When bullets enter the body, for a lot of reasons, based on velocity, based on the bullet tumbling, based on how the bullet opens up, based on what organs it hits, whether it meets bone, a lot of different things can happen inside. One of the things that helped this particular group of physicians figure out who really needed surgery and who didn't was when they were looking at the wounds on patients, in patients that were still alive and doing pretty well. They were trying to figure out which patients would have the worst internal injuries. And one of the things that this guy came up with is this thing called straight line theory, which is a very common sense thing. If somebody comes to you and they've got 2 bullet holes, most likely one's an entrance, one's an exit. And most likely the wound cavity traverses a linear line between them. That's a pretty good general rule. And the reason that's important is because sometimes people come in with more than 2 bullet wounds. Here's the example that he gives, but can still be shot with 1 bullet. And every time I hear that, I think JFK. It's like, still can't quite figure out how the bullet did all those different things. But the example he gives is somebody who has a bullet wound in the left upper quadrant, the left lower flank, and one in his arm, like here. Now, how could that happen? But in this particular case, the guy was like, this. So one bullet could account for all three of those. So the lesson there is generally you can figure out the path of a bullet if you've got more than one hole, and it's usually a straight line. The second basic thing about bullet wound injuries is that the inside of the body has usually what we call a cavitating wound. So the bullets carry a fair amount of kinetic energy, which as they meet tissue is translated into heat and destructive force. So in some cases, like in Vietnam, for instance, the bullets that the soldiers were given initially were fast and small. They didn't actually have a lot of kinetic energy, and you'd shoot another enemy combatant, and the bullets would pass cleanly through with doing a very little damage, and that person who was fighting them would still be able to fight back. And conversely, the Vietnamese were using bullets that actually were a little bit higher mass, and they mushroomed a little bit more. And if you got hit by one of those, even though they didn't go as fast or as far, you as a soldier usually suffered a lot more internal damage because the kinetic energy of the bullet was fully translated into a wound inside the body cavity. So that's basically what this lesson is. If you have bullets that are designed in certain ways, mostly to kill, they are usually ones that mushroom, or they have more mass, or they're fired with more velocity, so that there's more kinetic energy that somehow is manufactured to translate to a larger internal wound. So here are some of the lessons that this guy passed on after this experience. So the most important thing for him was to get patients who he'd stabilized or done some kind of evaluation. I know this patient's going to die without going to an operating room. So getting an operating room set up and getting patients to actually leave the ER and get into the operating room was his first chokehold. The second thing that I thought was really interesting was we spent a lot of time talking about this in triage scenarios for mass casualties. You know, the thing that usually shocks everybody, and I still always have dilemmas about it, is you got a person who is still alive, but you've got your resources are overwhelmed, and you could spend 10 minutes intubating, putting IVs, doing CPR on this person who probably was going to die with 4 people, or you could put those 4 people out, and they might actually be able to save 4 other people that would die when you're concentrating your focus on one guy that most certainly will die without intervention. This guy basically avoided that by saying, as a triage officer, I'm not going to assign anybody as a black tag. These are people that look like they're going to be dead in a few seconds or already dead. I'm going to move them into the red area, and if there are more resources than I have at the triage area, and the doctors there say, we can't deal with this, this is truly a black tag, then so be it. 2 people have said, this is the way it's going to be. But if I'm wrong, and it happens that Joe Schmo ER guy walks in the door right when we need another hand, that person might be salvageable. So he was very, very clear. I didn't have to black tag anybody, but I made it more of a group decision. And it was resource-based in all of our teaching. Limited resources, greatest good for greatest number. But there are lessons to be learned about being flexible. That doesn't mean that you spend all your resources on the one guy that's going to die if the resources are limited, but it means that you can still move those patients into a flow pattern that means that they might get some care if it becomes available. So this is, I'm just going to read this. It's important to get the red tags into the operating room because the orange tags would start to crump and become the next red tags. The yellow tags would start becoming orange tags. After 30 or 40 minutes, I triaged the sickest group of patients I'd ever seen. I noticed that the first cars carried most of the red tags, and now most of the vehicles had stable yellow and green tags. At that point, one of the nurses came running out into the ambulance bay and just yelled, "Menez, you need to get inside. They're getting behind." I turned to Deb Bowerman, the RN who'd been with me triaging, and said, "You saw what I've been doing. Put these people in the right places." She said, "I got it." So really, the lesson here is you don't need to be a doctor to do this kind of triage. Once you figure out bad skin color, bad carotid pulse, bad mental status, means those guys have to go straight back. You got it. And it only takes seeing somebody do that a few times before you realize you got those same skills. So I think anybody in this room could function at that level. This is interesting. In our systems now, it used to be when I first was working, all the drugs were open in cupboards, and anybody that needed them would just go, grab the Lasix or grab the epinephrine or even the morphine, and you take it and you do your thing, and there was good flow. Hospitals have stopped doing that for two reasons. One is that some of the drugs are controlled, and it's very difficult to keep track when somebody's abusing drugs or stealing drugs of where they're going if they're in an open box. So the transition actually was that those medications became locked, and one person was accountable for the key and checked stuff in and out, but the rest of the stuff stayed open. The second reason, which I think is prevailing now, is hospitals bill for every single dose of every medicine that is given, even an aspirin. So, and that's been a very lucrative model. But for patient care, it really presents problems when you have a lot of patients who need a lot of medications quickly, and every time you got to go put your fingerprint on, or a nurse, you got to find a nurse to do that. So in this particular case, they basically decided at some point to call the pharmacist, unlock the Pyxis, which is the big machine that locks it all in. And what they ended up doing was the pharmacist came down to the ER, pulled every vial. These two medications are what we use for intubating people in the ER most commonly. So every vial of those things, instead of having to check them out one by one, he just brought down the box of etominate, the box of succinylcholine, and handed them out to the nurses who were administering the drugs as the doctors were intubating en masse. And the same thing with blood bank. So instead of calling the blood bank, waiting 5 or 10 minutes for somebody to run down 1 unit of O negative blood or O positive blood, as the case may be, they just said, bring all the blood that you can that we can transfuse, and we'll decide after the fact how to record it for who gets what. Actually, I got another story to tell about this. I actually had a patient a few years ago who had a massive gastrointestinal hemorrhage. He was basically spewing blood out his rectum. He had a pulse when he came in, and he was conscious when he came in. And 5 minutes later, we were doing CPR on him. He was bleeding that quickly. We had IVs in him. We had a central line. We were pouring in fluids. I call the blood bank, and I say, we need O negative blood yesterday. I'm sending a runner down to get it. And the guy refused to send it without
An order.
Yeah, no, it wasn't an order.
Oh,
He
okay.
wanted a tube of the patient's blood to cross match it. And I'm like, we don't have time for that. He doesn't have any blood left. We can't get blood out of him. I'm asking for unmatched O negative blood, like your trauma system says. And he said, no. I couldn't believe it. And we went back and forth and back and forth. And I sent, finally, I just picked the guy in the ER who looked the biggest and bulkiest. He was one of the ER techs, and I said, you go down there and you strangle that guy if you have to, but grab the blood and bring it back because this guy's dead. We're doing CPR on him, and the only chance he has is if we put a little blood into him. But we're already 5 minutes behind the line. He's been pulseless for 5 minutes. And that's what this guy did. He went down, manhandled the guy in the blood bank, which I got written up for, brought the blood back, we gave it to him. And then we had all of these staff meetings after, like, you know, it's like, you honestly want me to explain why I needed that blood on that patient who was, you know, and the patient ultimately died. But it was a very interesting juxtaposition between administration and protocols and what we actually see in real life. Okay, another problem, they had a lot of patients who were shot in the head, and those patients need to have operations that involve neurosurgeons, and the neurosurgeons aren't there. So instead, what they did is they did all the things that they could up to the point of operation. So everybody with a headshot got intubated. Everybody, even the ones that were still conscious, they said, we know you're going to have to go to the operating room. When you're in the operating room, they're going to give you anesthesia and they're going to intubate you. So we're just going to do it now. We're going to put your IVs in. We're going to do the head scan because the neurosurgeons are always going to want the head scan. And then we're going to move you out of the ER, either outside the OR that you're going to go into or to the ICU, which is next to the OR, so that we can treat more patients. This is an interesting one. They ran out of chest tube trays. So a lot of people were also shot in the thorax, and they needed chest tubes so they could drain out the blood and pneumothoraxes. And generally, we have a lot of chest tube trays in the ER, but I think in Miles, you might have 5 set up. You use them up, and then what do you do? The thing is, a chest tube tray really is just a package. You open it up, there's lots of paper, lots of sterile stuff, gowns and whatnot. And it really has the instruments that you use to do it: a scalpel, some syringes, some towels for draping, some of the things that you use to get into the chest, but no tube. The tube actually comes separately, and the tubes are in these huge boxes. You can have a box of 30 or 40 tubes. You got plenty of tubes, but you don't have a lot of instruments to put the tubes in. So his solution was to use suture kits and scalpels, of which we have many. Most of the suture kits we have are disposable now. They're made, I think, in Pakistan. And some of the instruments are pretty nice, but you use them and you chuck them, which is, you know, the way it is now. But the thing is, you can use most of the instruments in the suture kits, which are tiny, to do the same thing that you would do with a chest tube kit. It just takes a little bit more time. It's not as efficient. You don't have the nicest tools. Instead of the other thing that he did is, instead of doing the traditional suture where you tighten the skin around a tube, he sutured through the tube to hold it in place, which is something that some people have taught in the past in mass casualty incident. When you're transporting, there's a lot of patient movement, you're not sure where patients are going, and you want the tube to stay in the right place, you just suture right through the tube. Oh, and when they did run out of chest tubes, they used endotracheal tubes instead, which are about the same caliber. Okay, I already talked about the importance of having IVs in, and this is the actual quote from Dr. Menace. By this time, all the patients had bilateral IVs. As the orange tags and yellow tags would become red tags, it became very apparent that those early IVs, put in while patients still had decent veins, were life-saving. As the patients decompensated, we had adequate access to rapidly transfuse and stabilize patients. If we didn't have that early IV access, we would have spent valuable time trying to cannulate flat veins. So that's just an emphasis of the prior point. And that's something that's we really appreciate when patients come in from the field. Even if it doesn't seem apparent that they needed IVs, if they have them and they need them later on, it's so much nicer than trying to dig around for something that's really difficult to get. This is a really interesting solution that I've never heard of, but they had many patients on ventilators that had been intubated or needed to be intubated. So many that at one point they ran out of ventilators in the hospital to ventilate them all. And some kid, I think it was the kid that they just hired, had read a study that said you could use one ventilator to ventilate 2 patients. It's like, how do you do that? It's like, one ventilator, one patient. And the way that they did that is they connected them with Y tubing, and you got to make sure that the patients are about the same size. So if you have a really big person, a little person, you can't do it because the little person will get too much air, and the big person won't get enough. But if you get two similar sized patients, we generally set the ventilator based on how much air or oxygen we think that particular person's lung will need to be inflated. And you just take that number and multiply it by 2 if you're splitting it equally using Y tubing. It's the first time I heard of doing this, but that solved their problem for running out of ventilators. Another problem was they ran out of monitors, which makes a lot more sense than running out of ventilators because they had so many patients come in. So I already talked about using more subjective measures to figure out which patients were the most critical. Same thing goes with monitoring patients. You can tell a lot if you can see the patients. So he had a lot of nurses watching lines of patients when they were off doing the procedures that they needed to, and they found that they could identify the patients who were going downhill easily just by watching them and using their own clinical judgment. The CAT scan issue was interesting. Generally speaking, when we order a CAT scan, the person who runs the CAT scan comes to the ER, gets the patient on the stretcher, wheels them down to the CAT scan, puts them on the table, straps them in, then goes to the machine, turns it on, programs all the stuff in, does the scan, and then does the whole reverse and brings the patient back to the ER. In situations like this, if you have 80 people that need CAT scans, and that person is spending 5 minutes or 10 minutes loading the patient up and unloading the patient and doing all the extraneous stuff, all that time's lost. So Dr. Menez basically went back there and said, you stay at the machine's on, and all I want you to do is press buttons, and delegated the movement of patients to other staff. So the staff basically had a line to the CT, and they would do the transport, lifting, transferring, strapping them in, step out of the room, the guy would punch the button, they would reverse that. So the flow of patients in and out of the CT was double or triple what it was during a normal operating period. These are all basically very small improvements to get patients to move through because they were overwhelmed with patients. And the last one that I'll mention is we order chest x-rays, say, in the trauma room when somebody comes in, if they have penetrating trauma or bad motor vehicle accident, we want to know if they punctured a lung or if their chest is filled with blood. In order to do that, we get a portable x-ray machine in there, it's shot, the image is digitally Wi-Fi to a server, there's a radiologist who hopefully gets it quickly, reads it into a dictation machine, and we got to call a phone number, plug in a code, figure out which patient it is, listen to the dictation to get to the bottom line, which is, yeah, the patient's got a chest full of blood or a punctured lung. So there's a lot of efficiency waste there. So what these guys did is they convinced the radiologist to leave the dictation room and come into the ER and walk around with the portable x-ray, which also happens to have a little tiny, like, iPhone-sized screen. So when the technician punches the button, you can see, yeah, you got the right image, but you can see a lot on that screen. So they just had the radiologist stand there probably with his magnifying glass and say, blood, no blood, blood, no blood. So they can make an instantaneous decision about whether that patient next went for a chest tube or to the operating room or could go back into the yellow or the green area. That probably saved them more time than anything else for these kind of system issues. All right. Overall, these 4 physicians and the whole rest of the hospital staff took care of over 250 gunshot wounds in 7 hours. This is the breakdown of chest, head, and abdominal wounds, and neck and major extremities. They were able to discharge 137 patients after their initial treatment, and they did 28 damage control surgeries, like I talked about, 6 hours. and then 67 total surgeries over the next 24-hour period. They had a full operating room schedule. They had like 5 operating rooms going from 11 o'clock at night, 24 hours straight. You can imagine. So here is a summary of the lessons that came directly out of this particular MCI experience. Flow is king. If you can work on and anticipate the places where patients will experience delay in their care and their movement through the ER to definitive care, those are the places that you need to be flexible and work on. Instead of spending a lot of time triaging patients, by writing on their forehead or tagging them, just move the patients into a zone where everybody in that zone is of the same ilk. And if you need to move patients back and forth, if you treat somebody and they get better, you can move them down or up. But you save the time that you would normally spend trying to put that data on the patient. Instead, move the patient into the area that reflects the data type. So they had basically 2 red zones. Their orange zone was an artificial one that they created, but they had people that were really, really, really sick and people that were just really sick. But that bought them just enough time that they could work on the really, really, really sick, and they knew that the people in the second zone weren't quite gonna die, but then they could work on those people next. And this is really what this guy, Dr. Menace, started the whole thing off. He's like, my mom thinks I'm crazy, but I spent a lot of time thinking about these scenarios. And in this particular case, it helped us because I had the wherewithal to consider all of these things during my practice. And we were able to put them in play. And he actually had staff meetings where he told the nurses like his crazy ideas, and they're all like, "You're crazy." But when the shit hit the fan, they all worked together as a team, and they all understood what they were trying to get to. And this did not happen at any of the other hospitals. The triage mechanisms were generally considered very chaotic and frustrating for most of the practitioners in the other hospitals. In many cases, those hospitals were higher level hospitals than this particular one. I've got a few more slides just about our particular lessons and some educational points. One of the things that Main EMS has actually brought up is whether we should be doing spinal mobilization. And this is back in the era when everybody was going on backboards anyway, so that's something we can take with a grain of salt because most people can just get neck collars and be just as safe. But in this earlier work, the lesson is that very, very often we overthink the spinal precautions for gunshot wounds, even gunshot wounds to the head. Very, very rare to have an associated spinal injury as a result of that kind of trauma. And some of this actually led to the change in the protocol so that we don't have to use backboards anymore. This isn't the only piece of data that helped make that change, but it was a compelling one. And that is in cases where we immobilize people, it turned out people died more often. That's backboard immobilization. So it's a really good thing. Not even considering the fact that backboards are really, really uncomfortable and people stayed on them for a long time once they got to the ER, even though we would try to get them off quickly. The emphasis for anybody with a gunshot wound is the ABCs, airway, breathing, circulation, which is bleeding and shock control, and then getting that person to a hospital with an operator will actually operate on them. One of the things I've thought about is in a mass casualty incident in our region, we would be contacting all the definitive level 1 trauma centers. So it'd be Bangor, Lewiston, Maidenhead, to see how many people they could receive, because that's where the next tier would go. And probably depending on the numbers, some would go by air, but you really can only transport 1 patient at a time by air. And so most would probably go by ground. And the Problem, of course, is that we're 90 minutes away from the next level one. So the question really is how many people could get into an operating room in one of the hospitals around here? And my guess is the closest hospital with a lot of operating rooms and capacity to do damage control surgery would be Midcoast, the nearest to us. Although I think we could convince our surgeons to open up the operating rooms and do as much as they could here too. So you're looking at possibly transporting some of these patients, if they're not red patients, let's say they're orange patients and they're yellow patients, directly from the scene to one of those other hospitals that has the capacity to treat them definitively if they don't need some intervention in the meantime that we can only offer them in one of the ERs locally. So for bleeding and shock control, direct pressure, we all have different types of hemostatic powder now. And one of the interesting recent studies that I read is a device for actually taking basically Celox or one of the hemostatic, which hemostatic powder thing do we have?
What do we call them? Well, click clop, but it's the strip,
Right.
packing strip, yeah.
So you can pack that into a wound. There are devices coming out now which basically are like tampon insertion devices that have the powder in them, and you stick them all the way in the hole, you push the plunger, and you're depositing crystals or pellets or something into the abdominal cavity. And the studies that I've looked at, some of them are very preliminary, but the outcomes are better. And it's fascinating, and this is all coming out of the Iraq-Afghani war theater, where we get a lot of research on penetrating trauma. Vietnam was the first. But that may be something that comes down the line. If you have penetrating trauma and you think there's a lot of bleeding internally, pack the stuff that you have as deeply as you can directly into the wound, and then put direct pressure. Bilateral IVs, we talked about that. And then one thing we don't talk about a lot, or really give a lot in the field, at least in the reviews that I've read, is this stuff called tranexamic acid, which we abbreviate TXA. Have any of you ever administered that to any patients in the field, EMS?
People on the service have.
Yeah, we carry it. And the reason I think we haven't done it in this setting is because you can get to a hospital pretty quickly from our zone. To review, this is a very inexpensive medication that was tested in a series of studies that were euphemistically entitled Crash 1, Crash 2, and there's a Crash 3 coming out. And they were done worldwide in tens of thousands of patients with hemorrhagic shock from some kind of bleeding syndrome, mostly trauma. The initial study was done in trauma. One injection of this stuff reduced mortality by something like 8%. It was a very, very meaningful outcome figure. And all it took, even in West Africa, where they have nothing else, was one injection to do that. The protocol that we have is one injection in the field or as soon as you can, followed by an infusion that goes on for a little bit longer. But this stuff basically is a pro-clotting factor. You give it to somebody directly by injection, and whatever's bleeding clots faster than it would have without it. So it helps with all the other measures of direct pressure, and in many cases is life-saving because the patient stops or slows bleeding enough that we can replenish the blood until they can get to definitive care. So it's carried on all ambulances in Maine. Don't hesitate to use it. If you feel like you need to, there are protocols that you can give it without medical control. In an MCI with gunshot wounds, with a system that's overwhelmed, I would say give it to everybody unless directed otherwise. It won't hurt people. And that was our big criticism. For a long time, the doctors would cogitate and pontificate and say, well, the cause is clotting. What about causing strokes? Because of all, we always think of these worst cases. And it turns out, if you look at the original data from all of these studies, it didn't do that at all. Nobody can explain how it works to stop blood where it's not supposed to be, but not, make extra clots where you don't want them to be. The data's good. So bottom line lesson is, if you have somebody who's got a gunshot wound, even if you're very close to the hospital, you can err on the side of giving it. If you have a mass casualty and there's a lot of people and you think the resources are going to be overwhelmed at the hospital setting, give it to everybody. Cautious, so this is shock control, further cautious fluid bolus to the systolic blood pressure of 90 millimeters of mercury. It used to be that we would consider 90 or below shock. And over the past 30 years, one of the things that we found is if we aggressively give volume through an IV to people that are in shock, who are bleeding actively, we push more blood out, and we dilute the blood at a faster rate, and the oxygen carrying capacity of the vessels in the body is reduced. And those people die at a higher rate than people that are left in shock, as long as they have enough volume in their bloodstream to pump around a little bit of oxygen. So 90 is the consensus for what we should be reperfusing to based on IV fluids. I don't think that's a new concept, but I need to reiterate it, because even in the ER, when we see somebody in shock, we just give them lots of fluid. And this is a particularly specific, different type of shock, because there's active bleeding, usually internally, that can't be stopped. And in those cases of shock, you don't want to give too much to raise the pressure too much. For gunshot wounds to the chest, in a situation like this, my feeling is everybody should get bilateral needle decompression. That at least gives us the information at the hospital. If you hear a rush of air or lots of bad stuff comes out, that person needs a chest tube on that side, without a doubt. If you put them in and nothing happens, you won't have hurt the person. But you may have saved them if they have a collapsed lung or a chest full of blood or other fluid that we don't recognize early on in the ER. It's a very quick maneuver to do. It's not something that we always do a lot of. Do we have needle decompression kits? I thought so. And if you don't have the kit, you can use a 16 gauge IV, just the longest one you have, second intercostal space, bit line, and you just stick it in, pull the needle out. And usually, whether you use a syringe or not, if the person has a collapsed lung, you hear air coming out. It's usually under force that you hear it come out.
Right.
Mm-hmm.
Yep. Okay, I think that's all I got for this, which is an interesting topic. Any questions? Any discussion? Yeah.
I think that one of these things that people need to understand, because we don't have this, we never have these things here, but not only you're going to have chaos on that scene where the shooter is or whatever it is, but you're going to have chaos at the hospital when everybody arrives. There's chaos at the dispatch center because they're trying to handle all the calls. There's chaos everywhere. So just because you've cleaned up your scene and gotten rid of all your patients off the scene, don't go, oh, the event's over. No, the event's still happening at other places.
Yeah.
And people don't take that all into the whole thing that's going on.
Actually, in my experience, the EMS side has been the easiest, because you get to a scene, handle chaos very well, patients get transported in an expeditious manner, and that's it. Two things that generally happen are we need debriefing, because these are the kinds of things that people have to talk about and understand and get their mind around. And second is, if you clear the scene and you're aware of chaos, especially at the hospital level, come in and help out, because the more manpower we have, and you guys do that very well, but we welcome that. It's really helpful.
Surgeries.
More hands.
Well, when they had that car crash into the people down at the ferry landing in St. George, my partner and I just went to the hospital, and we were knee deep in it for an hour or two.
Yeah.
Just helping out with patients. So we knew they were going to need it. So yeah, that's the thing to do. But I also think it's important for people to understand the roles and the responsibilities of everybody else. So therefore it works better. So you're not overwhelming others. And, people who haven't gone and done an MCI training, like I know they do them over in Knox all the time. Ray does them over there. You get to, do the tabletop, you get to do the exercise, you get to do the briefing, and you go. It's really very eye-opening if you haven't done it. It's well worth doing it. If people in EMS haven't done it, get involved with one.
Yeah, I think there's one coming up in mid-October that's going to involve MBA. I'll see if we can get it. Any other comments? Yeah.
Yeah, I have a couple of questions. For those of us that are responding to the scene, for whatever reason, if the triage tag system isn't working or they aren't there, in terms of you at the hospital, would you like to see patients marked some way with a Sharpie with their wound in red, yellow, green written on them? Or how would you like
if you have
to
time to do it, it still is helpful. So if you're going to a scene and let's say there are 10 people and you transport for them all, and you know that you got time en route to make some kind of evaluation, the more data, the better. And that could be something as simple as pulse, respirations, the patient's name, allergies, and you can, if you don't have tags, you can write it on the forehead. You don't necessarily have to relearn the tag system. You can just say critical or okay or needs more evaluation. That's a good point.
Another question has to do with transport. So in light of what you were talking about in terms of there was no difference in, survival of private versus ambulance transport. If you have a scene where, you have red people stacked up, and there certainly aren't enough ambulances, you let them go by private transport? I mean, if, say, a family member's there and they want to take them, or what? Yeah. I know that's not in the protocol, but what do you do?
I think the best answer to that is if you can do a little bit more triage so that you pick the people that don't absolutely need interventions en route so that you increase the survivability. But I have no problem letting as many people as want in a situation like this where there's limited resources, overwhelming numbers of patients, as many as possible go by private vehicle. The one thing that would be helpful is communications back to the hospital to say, look, we're at the scene, we've got help, people are going to be coming by truck and by private vehicle. We're trying to triage it so that the most critical people are coming by ambulance, but be prepared for 8 or 5 or 6 people coming in 3 cars in the next 10 minutes. Something like that would be very helpful. But I don't have any problem being totally flexible in how you transport those people. Any other questions?
In a situation like Jefferson with, licensing, the first responder, basic level, something like that. They don't transport. At that point, I mean, game on. You throw people in their ambulance and transport.
Non-transport rescues are allowed to transport MCI, I believe.
Yeah.
I don't think they even have a cot though.
They don't know how caught,
But someone on bench.
Exactly.
Backwards.
A few on the bench,
Strap
some
down,
on the floor. Go.
Yeah.
Exactly.
Stack them up, double them up.
All right. Well, thank you for your attention.
Thank you.
Coming in. And, any other subjects that you want me to cover over the next year or so, let me know. Let Sue know. And she'll pass them to me. And if you have any good cases, as always, love to talk about them. So send them in. All right. Yeah. So.